I hope you guys can, whoa, that got too big. Hope you guys can see my screen. You may or may not recall looking at the article. I got it right here. Very exciting article that was published on January 14th of 2021. Well, at least I thought it was exciting when I saw it. So I'm like, oh, I want to cover this in Journal Club. So this is published in the New England Journal of Medicine, and it's called Buproprion and Naltrexone in methamphetamine use disorder. So I'm using our little Journal Club template that we came up with. And so thanks to Sybil Marsh for providing a lot of these questions. So the first box underneath the citation is basically, what is the question that's answered by this article, and do I care about the answer? So the question I thought was, is the combo of injectable naltrexone and extended release bupropion effective in the treatment of methamphetamine use disorder? And the reason, oh, sorry, I gotta turn this off on my phone. Okay. All right. And the reason that I care about the answer is because more and more of my patients are starting to use methamphetamine and develop methamphetamine use disorders, and because there is no currently FDA approved medicine for any stimulant use disorder. So we got nothing for cocaine use disorder, nothing for methamphetamine use disorder. So that's why I was really interested and excited about this article. So the next box is, will the design of the study permit valid results? Or another way of looking at that is, how well was bias eliminated in the study? So this was what you might consider one of those gold standard types of studies that we read a lot about. It was performed at 8 different sites, double-blind, 2-stage, randomized, placebo-controlled clinical trial, and they used what was called a sequential parallel comparison design, which I will attempt to explain to you. But if you need more explanation, you can also refer to the handy dandy chart that is on page 142 of the article. So this is actually a, so what they did, what their aim was to evaluate efficacy and safety of injectable naltrexone, so 380 milligram Vivitrol shot. They gave the shot every 3 weeks, and then they also added 450 milligrams of extended release Wellbutrin or bupropion every day. So that's quite a bit of medication. And so this was a 12-week trial, and it was conducted in 2 stages, and each of the stages was 6 weeks each. So, so it's like they did a little 6-week trial, and then they did another 6-week trial right behind that. And the way they did it, and the reason that it's called a sequential parallel comparison design is, well, that's what I'll talk about when I get to stage 1 and stage 2. But first of all, they pre-screened 2,763 people who were between the ages of 18 and 65 that wanted to quit or cut down their use of methamphetamine. So that was the place where they started. And of those 2,700 odd people, they were able to get 403 people randomized. And they did the study between 2017 and 2019. So relatively recently, which is good. And so of the people that got randomized, the 403 people in that group, 109 people actually ended up getting active medication. The rest of the people got placebo. And of that 109 people that got active medication, 78 went all the way to the end of the trial. So what does it mean that they had this parallel, sequential parallel comparison design? So of the people that got placebo from stage 1, there was 294 people that got placebo in stage 1. Of those 294 people that got placebo in stage 1, they randomized 225 of those people basically into the exact same trial. So it's like they took all the people that were in the placebo arm that did not have a response, okay? And they said, okay, so let's randomize these folks. So they took 225 people, randomized them to the point where 114 got active meds, and then the balance got placebo again. And of that 114, 103 completed the trial. So you have to, this was a very sort of large funnel at the beginning with 2,700 people screened. And by the end of it, you had 103 plus 78. So that's 181 people that actually completed the trial with active medication. Okay. And then halfway through the trial, about a year into the trial, they had done like the power calculations, and they had said, okay, you need about 370 people to make this thing work. But then they sort of had to change that partway through the trial, and they said, okay, now you need 400 people in order to maintain 90% power to detect an effect between the two groups. So there was a point at which they actually had to recruit more people. So they went ahead and did that. So that was the basic trial, and they did it in those two stages. Now, I'm trying to remember the reason they did it that way is I think they were just trying to not increase their efficiency. Well, anyway, I can get back to the reasons why they did that. It was just interesting because I had never seen a trial that looked like that before. But let's talk about the population that they studied. And so the questions are, was there a selection bias of any sort? Is it at all similar to the people that I treat on an everyday basis? And did they address any confounding factors? So if you look at table 1, again, a very detailed table, you will see that the study population was 70% male, 70% white, 39% employed, had an average age of 41 years old. They were very, very active methamphetamine users. So when they looked back and asked the patients, on average, all the people that made it into the study had used methamphetamine on 27 out of the 30 days in the last month, which means they used it almost all the time. 35% of the population had a GED. 70% of the population smoked cigarettes, and they were all polydrug users. And you can, no, not all, but many of them were polydrug users. 36% of them met criteria for cannabis use disorder. 32% of them met criteria for alcohol use disorder. 7.3% of them met criteria for opioid use disorder. 8.5% also met criteria for cocaine use disorder. So I guess I would say when I was thinking about my own population, I certainly have more, my male to female ratio might even be flipped, where I think I have more women than men in my current practice. And 70% white is probably about right. Average age is about right. And so I would say that this group of people looked like the group of people that I treat. Maybe I would say that fewer of the people that I treat are actually employed at a rate of 39%. So, but otherwise, this is about right. In terms of who did they not let into the study, or what were the exclusion criteria, they excluded anybody that was in drug and alcohol treatment. So in that sense, it's not like my population, because most of my people are actively in some sort of substance use disorder treatment. They excluded anybody that had a planned surgery that was going to be needing opioids in the next several weeks. So they took those people out, and they excluded people that had conditions that increased seizure risk. They didn't really list all that stuff down, but that's who they excluded. And then, which I thought was nice, that they didn't just toss you out if you had a psychiatric disorder. They evaluated those folks on a case-by-case basis. So they did not say in the paper what criteria they used to let you in if you had a psychiatric disorder, and what criteria they used to keep you out if you had a psychiatric disorder. But at least they didn't sort of stop you right at the door. So I guess I would say that in that case, it's totally different than the population that I have, because 100% of my people have psychiatric disorders that are not a substance use disorder, I guess. Well, I shouldn't say that, maybe 95%. So yeah, probably these folks are not as psychiatrically sick as the people that I see. I also looked at the differences between the placebo group and the active treatment groups, and it looks like they didn't significantly differ from each other. So that was good. So it looks like they were able to get rid of most of any sort of like selection bias. And then you were asked to look at it or to think about the outcome measures, which is the thing that they were measuring the thing that they actually are trying to study, which a lot of times it isn't, or is it just a proxy? And then is the method for obtaining the outcome reliable? And in this case, their primary outcome defined a response as having 3 out of 4 methamphetamine negative urine samples in the last 2 weeks of each stage of the study. So in weeks 5 and 6, and in weeks 11 and 12, they did a series of 4 drug screens each in those last 2 weeks. And then if a person had 3 out of 4 of those that came up methamphetamine negative, then they counted it as a response. Okay, so you didn't need to be perfectly clean and sober from methamphetamine for 4 out of 4 drug screens. You had to have 3 out of 4 of them be negative. Okay, so 75%. So that's not too bad. And yes, I answered the question that yes, the outcome is measuring what you actually care about, which is methamphetamine usage. And yes, I thought that the method that they used was reliable because they used actual urine drug screens, not just patient reporting like, oh, I didn't use, in the last week, something like that. So, I mean, obviously you're not going to catch everybody, but that's pretty good. So what's the punchline? What actually happened in the study? So here the question is, what were the results and what do they mean? So for those of you that got a chance to look at this in some detail, you will notice that they got a response rate of, 13.6% in the naltrexone plus buproprion group versus a 2.5% response rate in the placebo group. So clearly not like the most exciting news in an article that I've ever read, but things are relative. So yes, it was a low response, but if you looked at the weighted response between treatment and placebo, there was a difference of 11.1 percentage points, and they called on something called the Wald Z-test statistic, which I won't claim to know exactly what that is, but the p-value was less than 0.001, which I do know what that means. They also mentioned this thing called NNT, or the number needed to treat. And so this they defined as the number of patients that you need to treat in order for one patient to have a response under the assumptions of this trial. And that was listed on page 151 of the article. And so basically you would have to treat 9 patients with this regimen in order for one of those patients to respond to the medication. So, and the lower the number needed to treat, the more effective a treatment is. So if you have a really high NNT, then it's not a very effective treatment. If you have a very low NNT, then you have a super effective treatment. So the most perfect or the best NNT that you can have is 1, which would mean that for every 1 patient you treat, every single patient has a response. So that's basically what that means. That's a perfect NNT is 1. So just to break it down for you guys a little bit, when you looked into stage 1, which was that total of 403 people, their response was 18 out of the 109 people in the treatment arm, 16.5% responded, whereas only 10 out of the 294 people that got placebo responded, which was 3.4%. And then in stage 2, they were able to randomize or enroll 225 people, and 13% responded in the active treatment group, where only 1.8% responded in the placebo group. So rolling along to the next box, are the results significant statistically and clinically? Well, certainly statistically, they're significant. Clinically, my personal opinion, I thought the numbers were low, 16% in stage 1, 11% in stage 2, for a weighted average of 13.6. So if I had to sum it up, I would say, heck yeah, this is definitely better than nothing, but not much better than nothing. Okay, so that was kind of like wah wah. I was like, well, it seemed so exciting when I started reading the article. Then I get to the punchline and I'm like, wow, this is really tough to treat. And what's interesting is, just in terms of background, is the reason they decided to put these two together is that in some much smaller trials that were not randomized, that were not blinded, they did have some effect from both of these drugs separately. So they thought, oh, let's put the two of them together and see if we can get an even better effect. So that's how they even got to this point, is that for years people have been thinking about buprenorphine because it's got dopamine and norepinephrine, responsiveness in it, that it might treat a stimulant use disorder. And then the reason they picked naltrexone was because we already know that naltrexone treats opioid use disorder, directly by the mu receptor, but it also treats alcohol use disorder. And it's sort of like this sort of catch-all for all addictions, you know, including gambling and all this other stuff. So they thought, all right, let's try that. So that's how they got to even conclude that they would try the two of them together. So what does this mean for me as a practicing doctor, you know, every day? Is this going to change anything I do or anything that I recommend? And so again, just me being honest with you guys, I'm definitely going to mention it to my patients. So if a patient comes in, and I have, again, several that come to my mind when I think about methamphetamine use disorder, I have several patients that pop right into my mind. I feel like I should at least tell them that, look, there's something that is out there that combines two medicines that we already use a lot. It combines them and it might work for you. I mean, you know, it'll definitely work better than placebo, but, you know, as far as how well will it work, you know, I'd have to give them the 16% number. What I was considering as I was thinking about if this was going to change anything that I did or not, was I'm not sure that insurance will cover that Vivitrol every 3 weeks. Because right now, Vivitrol in the FDA paperwork, it's supposed to be given every 4 weeks. The paper and the authors conceded that, you know, it starts to wear off after 3 weeks. And so that's why they were giving it every 3 weeks. So you'd have to get the insurance companies to change their policy and start covering more doses over a shorter time period. So that's one thing. And then just again, would I actually start somebody on this regimen? I'm not sure I would. Like I said, I'd tell people about it, but I'm not sure I would actually start somebody on it since the efficacy is so low. My other bias or my other problem is that so many of my patients are doing well on buprenorphine. And in order to get them onto this regimen, I'd have to take them off of buprenorphine, make them wait 2 weeks after the buprenorphine to get them onto the shot. And then I'd have to start them on Wellbutrin if they weren't on Wellbutrin already. So just makes it a little bit difficult. Maybe if I had somebody that was brand new from the get, that was methamphetamine use disorder and opiate use disorder, definitely would consider it. Like if I saw somebody like in a psych unit that needed help or a detox unit. So anyway, and then just a couple of my editorial comments here and observations. And again, I would love to spend some time listening to what you all thought of the article and if it would change anything that you do. Certainly this trial had very low attrition and high adherence. So most of the people that they did randomize made it to the end. But remember that these folks were paid for the trial or compensated in some way. They didn't exactly say if they gave them money, and they didn't say how much, but they just said everybody was compensated for participation. So again, not sure how that translates into real life, because to me, that's sort of like, what is it? Contingency management. We'll pay you to be in this trial, right? So there's some contingency that was in there. Also, the trial was so short, and I know it's hard to do these studies. And I admire people who have the fortitude to do these studies. So I'm not trying to bash on the study, but again, the trial was short. It basically was 2 6-week trials put together back to back for a total of 12 weeks, which also is not real life. I mean, people with methamphetamine use disorder with 4 other addictions, you know, this is something that's been going on for years. Clearly there was a low representation of women in the trial, but the authors did make the argument that this is actually consistent with the way methamphetamine epidemiology is in the United States. So typically methamphetamine use disorder is more common in men than it is in women. Now, again, of the patients that pop into my mind, 3 of them are women. So maybe my population is just skewed, right? So I have women that use methamphetamine with some scary outcomes and results. I also thought that they teased a little bit with these so-called secondary outcomes. So they said, oh, well, we measured these secondary outcomes, but we couldn't really make any statements about them, but we'll tell you about them anyway. And I'm like, oh my gosh, that's like total tease. So some of the things that they measured in terms of secondary outcomes were, they were looking at the percentage of patients that had methamphetamine negative urines in the one group versus the other. So in the active treatment group, the percent of patients with methamphetamine negative urines was 6.8 percentage points higher. The craving scores were 9.7 points lower on the scale that they used. the PHQ-9 score, which is what they used to measure depression, was essentially, identical. So it was 1 point lower in the treatment arm. And then they had this thing called the treatment effectiveness assessment score, which I think is sort of like a little scale that you use to see if patients feel they're benefiting from treatment. That actually was like 4 points higher in the active treatment group versus the placebo arm. So again, I don't know what all that means. The authors basically said, we don't know what all that means, but since they had them and they measured it, they just decided they would tell us about it. So I was like, okay, that's fantastic. The only other thing that I left with a little bit of puzzlement about at the end of the reading the study was they seemed to define number needed to treat differently than I've seen number needed to treat in other studies. And I wasn't sure if anybody on the call knows more about NNT than I do. I mean, like I said, I'm not a researcher by trade. I don't do research as 50% of my job. So in this article, they said that number needed to treat was the number of people that you would need to treat in order for one person to have a positive outcome. And then if you look online, the definition that pops up for number needed to treat is the number of patients that need to be treated to prevent one additional bad outcome. And I'm like, it doesn't seem like exactly the same thing, but maybe it is, or maybe I'm just confused about what NNT actually is. So that was just a question mark that I kind of had left hanging at the end. So I'm going to stop there. I'm going to stop sharing, but I can always go back to the paperwork if you want me to.